I just want to start off by saying that it's so nice to be able to talk to folks from Arkansas. I've got family in Rogers. So if you have run across a Jack or a John Gracie, those are my great uncle and my cousins. So it's nice to be back and to be able to speak with you in Arkansas. I hope to get back to Arkansas soon. It's a lovely, lovely place, and I have a lot of great memories of visiting there. So today we are going to talk, just have a conversation about transforming rural healthcare through telehealth and virtual visits. We are going to talk about a variety of aspects of telemedicine, and I hope that I can provide you some information that will help you in implementing telemedicine. So goes without saying that we are just one telehealth resource center, the Heartland is, and we're a proud member of the National Consortium of Telehealth Resource Centers. That's the map that it actually shows all of our regional telehealth centers in the states that they serve. But also there are 2 national resource centers that are located on the bottom left corner of this slide, and one is called TTAC. I'm going to talk a little bit more about that in a little bit. That's the Telehealth Technology Assessment Center, and the other is the Center for Connected Health Policy. That National Telehealth Resource Center actually helps people understand what's going on in their state, and as well as what's going on federally when it comes to policy and regulations for telehealth. And boy, have they been busy in the last few weeks and months. So that kind of gives you an idea. We are funded by HRSA through the Office for the Advancement of Telehealth, and so we are grant funded, and our services provide a variety of things for you when it comes to technical assistance for telemedicine. So we can help you look at choosing equipment. We can help you with some policy. We have templates that, don't go recreate something when you can utilize what we have, and we can help with that program development and much, much more. So we do that free of charge because we are a telehealth resource center federally funded. We do this by providing online resources, and all of us have websites that we place information on, and then the National Consortium has that website, overarching website. We have workshops and presentations, staff training. There's just, an endless array of things that we can do to help you implement telehealth. So I always say that the most successful telehealth programs begin with assessment. So, looking at what it is that you want to provide your patients. And so before COVID, we have this process called eSTART at the Heartland Telehealth Center. And it's a series of questions that, we put administration and maybe a task force through in order to assist people trying to look at telehealth, plan for telehealth before that implementation. And so we would look at organizational assessment, program development, some of that operational support. What's your reimbursement going to look like? Now, pre-COVID, that sometimes was the make it or break it part of telehealth. We'd look at equipment, and we would take a long time to go through all of these steps so that we could, try to increase buy-in and make sure that we were unlocking the revenue streams that the organization needed. Perhaps they already had a telehealth program, and so we could build on existing programs and develop additional protocols or policies, and just overall determining the needs of the organization. So we know that the benefits to telemedicine, prior to COVID, we said, okay, it helps improve healthcare access. We know that. It does reduce unnecessary patient transport. And one of my favorite stories is a child that lives in South Central Kansas who had a 5-hour trip to see a pediatric psychiatrist. And it was daunting for the family, for the child. They had to, take time off of work, take the child out of school, perhaps a hotel room, when they got there, because of the fact that, maybe the appointment was early in the morning, and just, it was, arduous. I mean, they just really had a difficult time keeping those appointments and continuing that care, until his primary care provider at a small critical access hospital said, why don't we create this telemedicine room so, our patient can see that specialist without having to travel. And it's just the right thing to do. I mean, that they weren't going to get a lot out of it other than maybe the originating site fee that people get when they are that originating site. But they created a room that child could go into with his parent and see that psychiatrist, and his care, of course, his health outcomes increased, and he was able to keep those appointments. And instead of a 5-hour, ride in a car, maybe it was a 5-minute trip to the hospital so that he could go to that room and be seen. So there are a lot of things. So that's a young patient story. And then there's older patient stories about, how difficult it is to travel with some of our elderly family members and get them to a specialist if it's hours away. Of course, it addresses some of the healthcare provider shortage. There are areas in rural America that, I as much as we want our new doctors and nurses to practice in rural areas, sometimes they go to the big city to med school, and then they don't want to leave. And it's hard to get them back. And so to address that healthcare provider shortage, we see that as a benefit of telemedicine. Also, some of our providers travel from their clinic to maybe a satellite clinic, and we can help reduce that windshield time, if you will, if they would just use maybe follow-up appointments for telemedicine and that type of thing. We're talking about the travel and time and cost. We have already talked about that. I just really think that it's important that we continue to retain patients locally in their home communities. It's better for them. It's better for the health system in that small community. And I think the health outcomes are much better because the family stress does go down. So if telemedicine is so great, what was the resistance to telehealth? Okay, well, a lot of people were uncertain about HIPAA and technology. There was a lack of training for both physicians and for staff. And there still may be a little bit of lack of training in some of our educational systems that are, training our healthcare providers. We need to do better and get them familiar with telemedicine. Maybe preconceived notions that my patients won't like this, but I think people are surprised when they find out that patients actually do like telemedicine, and it doesn't matter the age. There were licensing and credentialing problems. There was, of course, concerns about proper reimbursement prior to COVID, and concerns about malpractice. So those were the resistance. So that's what we kind of had to fight prior to March. Then enter COVID-19. That kind of set telemedicine on its ear a little bit. It really did make telemedicine a household name, actually. You heard a lot about it on the news and on reports that telemedicine was the way to go because they didn't want you to come into the waiting room and that type of thing. And it really took the doctor will see you now to the patient will see you now. And this Eric Topol book has been out for a while, but it's just so true right now that actually the patient will see you now. and it is very consumer driven. Telemedicine is, and so people are wanting it. Once they experience it, they like it. And so I think, you know, the future is absolutely now. We grew telemedicine probably a decade in a matter of 2 months. And I kid you not, there were changes made that we were shocked that actually those changes were made in reimbursement and in some of the things that they allow us to do now that COVID. But this is actually, okay, this kind of reminds me of hot springs, because my mom and dad would take me to hot springs to the horse races a lot, and when I was a kid. And so this is kind of what telemedicine looked like when COVID hit. You know, it's like out of the chutes, and they're off. And but look at the horse race. I mean, they're very organized. You know, they're color coordinated. I mean, just look at how beautiful that is. But in reality, the horse race kind of looked like the picture at the bottom. It was kind of a wild, chaotic ride because people had thought about telemedicine and didn't quite know how to implement. And they were implementing like overnight practically. My son is a pediatrician in Kansas City, Missouri, and he called and said, okay, Mom, he goes, we're going to implement telemedicine. We have a meeting Saturday morning. Okay, this was a Friday. We have a meeting Saturday morning, and they sat down and got everything going, and they implemented, I thought, in record time. The next Monday, they started their telemedicine program, but that was it was just amazing. So now that you know, we're out of the chute, so to speak, you know, this reminds me of Bob Marley. The day you stop racing is the day you win the race. But let me tell you, telemedicine really isn't a race. Okay, it's not something that you win at the end and you say, okay, I won and here's my trophy, we've got it, we're done. It's more of a marathon instead of a sprint. Okay, you're going to continuously go back and look at your telemedicine program for quality improvement purposes, because it changes so rapidly that it's important to keep up to date. And we're going to talk about how your organization can easily do something like that. Just a couple of websites I wanted to let you know about in terms of COVID-19 and telemedicine, because the changes in regulations were so fast and furious. I mean, we were like flexing on a dime, seriously, when we were doing TA, because something would come out and then the calls would come, and then we'd have to learn what was going on in order to provide that advice. So we keep up on these resources, and the Center for Connected Health Policy, which is this top website, is something that keeps track of all state related actions. And then also there's a ton of COVID-19 resources available, toolkits and that type of thing, on that telehealthresourcecenter.org, so that you can keep up. So when we talk about implementing telemedicine on a, you know, like out of the chute, and we had to do it so quickly and that type of thing, now that we are kind of, I'm not going to say slowing down, because all of a sudden things are ramping back up again, and you know, we just don't know what tomorrow holds sometimes. But the fact of the matter is, now may be a good time, if you haven't started telemedicine, or if you have a program that you implemented quickly, that it might be a good time to go back and take a look at it and see what kind of gap analysis that you can do in terms of where you're at and where you want to be. But before we get started, I really do want to talk about some terms. Telehealth is used and telemedicine is used interchangeably. But I want to provide you with my definition of what I'm talking about during this presentation. You're going to find that there are different definitions out there, and some of our payers have their own definitions. And so you really have to understand and become familiar with how we're defining telehealth and telemedicine, and then how others define it as well. But for the purpose of the Telehealth Resource Center, we use HRSA's definition. Telehealth is that umbrella term, I call it, that really encompasses a lot of different types of ways to connect with patients through electronic. So it definitely is clinical healthcare. It is patient and professional related education. I'll give you an example of that here in a minute. Public health can be under telehealth and determined. You can use health administration and call that telehealth as well. So an example of telehealth would be using Project Echo to address health education issues. Now, Project Echo has been around for a long time, and Sanjeev Arora from the University of New Mexico started Project Echo in response to a hepatitis epidemic, okay? And he was one of two specialists in the state of New Mexico that patients would, make appointments with, and he had a 9-month waiting list for patients. Incredible. So he said, this has got to give. I mean, we've got to find a way to assist our patients. And so he decided to give his expertise away. He used live interactive video with primary care physicians throughout the state to help them learn from him how to manage hepatitis care for, their complex patients. And for the more complex ones, then he could see them through his appointments. But it was kind of demonopolizing medical education and giving his expertise away so that they could be treated in their home communities and get access to good care quickly. So now we use Project Echo to discuss a lot of different options and topics. So it doesn't have to be hepatitis. It can be autism. It could be behavioral health. We have done pain management echoes, because the fact is that, there are several ways that we can manage pain now through a variety of systems instead of just the opioids. And so that's how some people are, getting some of their money for that opioid problem, and they're using Project Echo to help do that. So the next slide shows just an example of a telehealth addressing behavioral health disorders. And so this is just one example of what we're doing. We are doing actually a Project Echo for telemedicine, okay, and where we have providers come and we meet like the second and the fourth Tuesday of the month in our region, and we just talk about telemedicine, whether it's platforms, whether it's technology, and we learn from each other that way. So you can echo almost anything, actually. Now, telemedicine, that is the actual use of electronic communication to provide clinical care at a distance. To me, that's that patient and healthcare provider one-on-one appointment. So that is what we refer to as telemedicine. There are some other terms that are very important for everyone to know when starting a telemedicine program. So the distant site, you probably heard me talk about the distant site. That's the healthcare provider location. The originating site is the patient location. A telepresenter helps facilitate an exam at an originating site. So remember my little guy who saw his pediatrician psychiatrist? Well, he had a telepresenter that would help start the appointment at his site. And then, the telepresenter can leave the room or stay in the room depending on what the specialist needs at that point. Some states require telepresenters and others do not. So you have to look in your state regulations to find out what that regulation is. Asynchronous or store and forward would be data transfer from one site to another. That is, a lot of times dermatologists will transfer photographs and that type of thing. So that would be a store and forward way of seeing. Teledentistry uses store and forward, and yes, dentists use telemedicine. Actually, hygienists can go in and use a mouth cam, take pictures of a child's mouth, say at a school, and then send that on to the dentist. The dentist can look at that and create a treatment plan for that patient. So that's an example of store and forward. And then remote patient monitoring, that's using those digital devices and sensors in patients' homes, and that data is transferred back to a data bank so that providers can look and see what's going on and care for the patients that way. So telemedicine is face-to-face, but it's not in person. So an in-person visit is you're in the same room. Telemedicine is live interactive video that requires quality, reliability, and encryption. Now, in the COVID era, that's something that CMS said, no, you can use FaceTime, you can use personal Skype, those types of things, just to make sure that people have access to healthcare. So, but best practice says that your platform needs to be secure and it needs to be encrypted. And in order to prove that you have that kind of platform, it requires actually a business associate agreement. And a BAA is something that you can keep in your file, that if you ever have an audit, you can show that you have this business associate agreement, and then your platform company could actually prove that during appointments that there was no interference by any outside parties. All right, telemedicine then and now. Telemedicine, and telemedicine really isn't that new. It's just taken a while to get it going. In the early 1990s, this picture on the left is actually an oncologist at KU Medical Center, where he had to go to a telemedicine room. His name's Dr. Doolittle, by the way. He's not a vet, okay? He's an oncologist. But he had to go to the telemedicine room and connect with different parts of the state. Now, Dr. Edison on the right-hand side, this is her office, and that's her setup. She has the dual monitor setup where she can see the patient on one screen, and on the other screen, then she can have her medical record pulled up and be entering that type of information. She doesn't have to go to a room across the building or across the hospital. She can just go right to her office and be fine. So that's kind of her setup. And so now, when we talk about how do you get started and what kinds of things do we have to think about, well, I think it's best to bring a team together. Developing a telemedicine program in the comfort of your own office away from everybody else is not probably the way to do it, because you need input and you need buy-in and you need to get everybody around the table so that you can all decide what it is that you want to achieve for your patients and for your organizations. You'll have to look at those service lines, what is it that you want to deliver? And then look at the technology. And as we go on, the people to keep in your circle and around the table with that committee or task force or whatever you want to call it, of course, healthcare providers, professional colleagues, the clinical director, of course, billing office. Don't forget the billing office people. They are critical to the success of your telemedicine program, because once they know that how to make sure that everyone knows how to code telehealth and telemedicine appointments, then you're going to get paid, okay, and reimbursed, and that's the name of the game. The schedulers are very important. Your frontline staff, the people that greet your patients, are critical to the success of this program as well, because the last thing you want is a scheduler to say, well, we have one of those telemedicine appointments, available. I don't know if you want to use it. So, in order to bring them on and have them get into the buy-in of telemedicine, include them in the planning. IT, of course, don't forget the IT. And then if you're lucky enough to have somebody who's responsible for marketing, then make sure that they're on board as well. So there are some telemedicine readiness questions that are asked when we first work with an organization, and they're things that you can sit and ponder yourself right now. Do you have a champion? Do you have someone who really thinks telemedicine is it? Okay, you've got to have somebody who's excited about telemedicine, because it takes time, and it's passion for some people. Do you have the equipment? You may already have equipment. You may not have to go out and buy much at all. So look at your equipment. What is it that you have that may work? And we'll talk more about what that is in a little bit. Do we have the staff that would be able to do this and want to do this? Do they have time to do something a little bit different? Can you maybe change some of their job description just a little bit? You don't have to hire a telemedicine coordinator unless you want to, and you have a lot of money burning a hole in your pocket. But the fact is that it's really important that you have somebody who's kind of coordinating things for you. And the leadership. Do you have the leadership behind the telemedicine program? So those are some quick questions. These are the kinds of questions that we asked during this organizational assessment that, you know, we went on at probably ad nauseum, okay, prior to COVID. We looked at the organizational assessment. Then we looked at workplace assessment. You know, do you have a room available for telemedicine, or are you going to use a cart? Is it going to be mobile? What's this going to look like? And then we looked at the technical assessment. Do you already have some of that equipment? You know, you can do telemedicine with a laptop if you really needed to, an iPad, a smartphone, because that's how we're connecting with people at home now, which we were really never able to do prior to COVID. A desktop, just like you saw in Dr. Edison's. You need a webcam, okay? You need speakers. Then, you know, your providers are probably pretty ready to go, depending on where they're connecting with the patient. So there's just, you know, some of that basic equipment that you may already have that you can utilize. And we'll talk a little bit about peripherals here in a little bit. So step 2, you decide on the type of service that you want to provide. Really low-hanging fruit is the best way to go in terms of what is it that you think that would be manageable. So is it follow-ups? You know, follow-ups are a real good thing for some people to start with because it's easy enough to do that. And then maybe dietitian programs, you know, diabetic education, that type of thing. Those are things that you can get started with as well and get reimbursed for. So you decide on that type of telehealth program. You consider, you know, what are the opportunities, what are your strengths, and create kind of a written proposal. Now, this is where a lot of people, you know, of course, fell off the planning bandwagon because that did not happen when they were implementing telemedicine during COVID. But it might be a good idea if you did implement telehealth quickly to go back and start maybe writing some kind of report about what it is that you're doing and how you're doing it and what it looks like, okay? Because once there's money available, and there was a lot of money available, and there still might be just a little bit going out there for COVID and telehealth programs, that you are ready to write maybe a funding proposal so that you can increase your equipment or increase your FTE in order to get going. So it's always a good idea to get things written down, and really for historical purposes too, because how many times have it, well, when did we start that, or, you know, that type of thing. So make sure you've got some really good documentation on your program. So we assess the lines of services by what's appropriate, what's appropriate for telehealth, for televideo, what's appropriate for telephone, because we're now getting reimbursed by telephone as well, okay? And what appointments must we have in person, okay? So assess those lines of services. And then when you're thinking about if you're the distant site and you are connecting with patients at an originating site, what appointments are appropriate for that site, and are there peripherals available? And we'll talk about equipment here in a little bit. So things to consider is that provider availability. You know, we talked about that coordinator. So this is just things that you can look at to consider when you're sitting with your committee and saying, okay, is this something that we can do? Do we have the resources to do that? And how about the originating site? Are we going to be the originating site, or are we going to be distant site, or are we going to be both? Because you can be both as well. So reimbursement, huge. Medicaid, of course, different in every state. I am not lying when I say there are 50 states, therefore it feels like you're dealing with 50 different countries when it comes to Medicaid. But they've come a long way, and most states are reimbursing for telehealth and telemedicine now, of course, through COVID. Medicare, CMS just did a yeoman's job in trying to roll out some of these new things. However, they were really slow on getting the FQHCs and rural health clinic regulations out, if you'll remember. Those didn't come out until May. But when we look at Medicare and we listen to the CMS administrator, they are really championing telehealth and trying to make some changes permanent that have been made. I think the CMS administrator was the one that said, you know, the genie's out of the bottle now, and it's going to be hard to put it back in after people experience the ease of telemedicine and the safety of telemedicine during the time of COVID. And then private insurance has kind of come along as well. They usually follow Medicaid and Medicare when it comes to making new policies and regulations. But they're also the ones that sometimes have their own definitions of telemedicine and telehealth. So you've got to, you know, be on top of that. I just cannot tell you how many times that I've had organizations say, I just had no idea what they were talking about. There's one payer that says telehealth is direct to consumer. So they have like American Well as their telehealth provider for their insurance, their programs. And they said that was telehealth, but telemedicine was with the provider. And so it's just, sometimes you really, really have to do your homework and make sure that you're on the same page as them. Other considerations, we talked about HIPAA, you know, the quality, staffing, those types of things. We'll go through that. We talked a little bit about gap analysis already, and really it's just that, what is your current state and what's your desired state, and how do you get there? And the easiest way to do that is usually through the SWOT method, the strengths, weaknesses, opportunities, and threats. So that's a good way to look at making those improvements for your telemedicine program. Here are some examples of primary care clinical use cases for telehealth, and we've learned these pretty quickly through COVID, but at the same time, it's just important to see what others have done and used telemedicine with. So, you know, like I said, a lot of the chronic health diseases can be utilized with telemedicine appointments, and definitely med adjustments, managing side effects, lab results. I mean, plan management, care coordination, those types of things can be paid for now. And wellness exams and follow-ups, we've talked about that those are great ways to use telemedicine and be paid for that as well. Someone said, oh, how could you do an annual wellness visit? Well, you know, your annual wellness visit always is just a lot of listening to the patient. So because they have a health risk assessment that they usually need to fill out and talk about, maybe we need to update the family medical history, what's going on with their medications, and that type of thing. And there's lots of screenings that can be done through telemedicine. And so this is an example of that very thing. So then we start talking about a business case when we would do this, you know, eSTART assessment and developing that business case. And really, a lot of people are wondering about what that return on investment is for telehealth. And sometimes telehealth, sometimes it's different. To do that, your return on investment sometimes is because number one, it's the right thing to do and we have to do it this way. But also the fact is that you can look at miles saved for patients, miles saved for providers if they're not going back and forth to clinics and that type of thing. So there are different ways to measure, you know, telehealth. So to look at that ROI before you really get started in that evaluation process and using that business case to help develop perhaps a survey that you may want to have pop up on the screen after the telemedicine visit, asking certain questions so that you can keep an eye on that. So definitely that is something that probably people need to go back and revisit as well. It's so important to have those protocols in place. And like I said, don't recreate the wheel. We have protocols and templates, all of the telehealth resource centers do, that can help you and guide you through this, because some of it is like, you know, 15 minutes before the appointment, make sure the equipment is working. You know, there's nothing worse than technology that doesn't work and, you know, you're trying this new program. So, so it's a list of things to do to prepare for the patient and to prepare for the provider before the provider shows up on the monitor if you are the originating site. The detailed technology plan, that IT can help out with that, and then that performance monitoring plan, like we talked about, some evaluation aspects with patient satisfaction, provider satisfaction, which is incredibly important as well, and just so that you can monitor those benchmarks. We talked a lot about the HIPAA compliant video conferencing. There are many, and I don't have a dog in this fight. We are vendor agnostic at the telehealth resource centers, and so we just, you know, help people look at different platforms, and really it's what's best for you. There are many organizations that may use the Zoom for their platform, but it's the health Zoom, it's not just the business Zoom. So there is a difference. So, you know, there are many. And so that's something that it's really important that we look at that technology and what's going to be best for you. So what are some of the trends? Well, most of them are web-based, okay? They're in the cloud, and they're not stored in these, you know, huge servers anymore. So that's not a problem. A lot of these video trends, of course, we need to be able to connect to patients in home right now. So it's important that we have something that's easy to use and easy for patients to use as well. And a lot of them are link-based. In other words, you don't have to download an app in order to see the provider or to see the patient. You just click on the link. So 5 key platform dimensions when we're talking about these kinds of platforms. The deployability. So can you use this platform across all things? I mean, on an iPad or on an iPhone or on a monitor or on an iPad or a laptop, okay? So, you know, how can you deploy that throughout the organization, and is it gonna work? And are you able to scale that up You know, from starting with one line of service, will it be enough to handle more? Are you going to have to buy multiple licenses? That type of thing. Reliability, and I don't underestimate the ease of use. If it's not easy to use, providers will not use it, okay? And the security and privacy of it. I know that right now you don't have to have that, but it's important to plan past the crisis and use best practice. And best practice would be to have a secure and encrypted platform. Is your infrastructure ready? Do you have sufficient bandwidth? That's important. These megabits per second are important to look at. And you have to know that the Mbps has to be for upload and download as well. It's kind of funny, in small towns, I work with a little community that has their own telephone internet service, and they would have trouble about 3 o'clock in the afternoon. They couldn't figure out why. Well, all the kids were coming home from school and gaming, and so it really sucked the broadband out of the community, and especially out of the doctor's office. And so they had to really plan for that and not have those appointments during that time. All right. And also the most reliable. You know, you can do a lot by wireless, but you know, some of our buildings have a lot of concrete and steel, and it's difficult at best sometimes to get a good connection. And so the most reliable is to hardwire your equipment directly to the modem. And so it really does help with the speed and the image and the quality of the telemedicine visit. So equipment, there's really no need to purchase the excessive amount of equipment. You do not need a robot. This robot on the left-hand side is wonderful. I mean, you know, it can go from room to room, and you know, it's quite fun to use actually, but you don't have to have that. This picture here of this couple looking at this tablet, okay, that is a ALS clinic that we helped create in Wichita, Kansas, to connect to Kansas City. We had a lot of ALS patients that saw our neurologist at the Med Center in Kansas City. And that 3.5-hour drive and trip was just excruciating to not just the patient, because think about if they had to get out at a rest stop and use the facilities and the caregivers with them, and just the stress of the whole thing. So we developed this ALS clinic where they could see all their ancillary services, including PT, a dietitian, speech therapist, their equipment, the equipment guy who, you know, makes sure that the wheelchairs are working appropriately, all in one morning. And then at the end of all of those appointments, then they would see the neurologist, who would also confer with all the ancillary services about the care of the patient. So that left, they didn't have to go, you know, one day to PT, another day to a speech therapist and that type of thing. And it really made life a lot better for the patient and the family. But we just positioned a tablet on a quasi IV pole type thing and put a coat around it and a stethoscope and called him Virtual Dr. Barron. And it worked out quite well. So you don't have to spend an inordinate amount of money in order to make this telemedicine program work. Here's some, we talked about peripherals, and so here's some of those peripherals that you might find at an originating site, so that the doctor can hear and see heart sounds through that electronic Bluetooth stethoscope, the exam cam, and so that they can see wounds or whatever it is they're looking at, okay? There's the otoscope, a wireless otoscope even. There's so many peripherals out there, it's incredible, but you don't need to purchase a lot of peripherals either in order to make the telemedicine work. I will say that this at-home device right here is available at Best Buy for under $200. And I suspect someday that most households will have this device that can connect to their smartphone, and one acts as a stethoscope. There's an otoscope there, you know, and so a full-fledged appointment could occur. All right. Patient sites. This is what a patient site could look like, an originating site. This top left one would be excellent for behavioral health. And because, you know, it's just in a room alone and that type of thing, with the pan tilt zoom camera that the provider can zoom from their end. And then here's some examples of some carts, as well as even a desktop monitor in a patient room. So you can do this with equipment that you may already have. Just don't let your provider distance site look like this picture, okay? But, you know, do you have that webcam? Do you have the audio? Is it private? Is it good acoustics? And is it comfortable enough for that physician to be able to do some appointments in that area? Again, here is this Telehealth Technology Assessment Resource Center information, telehealthtechnology.org. You can find a variety of information on here concerning the equipment for telehealth, and it is like they'll write a review of it without you having to listen to a salesman, okay? I think, and that's what I think is the greatest thing about the service of that. And remember to use products that really can integrate with your existing equipment. That just cannot be stressed enough. There's no use of doing something that's so difficult that, you know, it's not going to work with all the equipment that the organization has. And then finally, you get to implementation. And I make this point that think of all the steps that you have to do to get to implementation, and think about how quickly we had to go and get implementation going during COVID. This is the fun part, okay, the implementation, but there's so much work that needs to be done prior to implementation to make a great telemedicine program. And don't forget to market your program on your website, wherever, on the back of the patient room doors or whatever. Say, hey, remember we have telemedicine, or that type of thing. There are a variety of ways that you can make sure that you have that marketing covered. There's no use of having a telemedicine program if no one knows about it. So I like to kind of end some of this with this slide, because at the root of telemedicine, there are several roots that we have to pay attention to. In order to get this beautiful tree, okay, you've got to take care of the root system. If you don't have the root system, that tree is just going to fall over and die. So much like a program, all right, that if you don't develop that program in the right way, then it probably will fall over and you won't be able to resurrect it. A lot of people said, oh, we tried telemedicine before and it didn't work. Well, you know, it's a different time, you guys. There are different things going on now in terms of reimbursement, especially with COVID, with patient safety, with us being able to see patients at home, that it is almost one of those things that if you don't do telemedicine, you're going to be left behind. People ask me if I know what's going to happen after COVID. I have no idea. I wish I had a crystal ball, believe me. But telehealth has been around, and in the Heartland region near St. Louis, there is a place called Mercy Virtual, where doctors and nurses go to this hospital, quasi-hospital, every day and see patients, but they're definitely not in that building. The patients are seen by monitors and through telemedicine. So they have saved millions of dollars for that program because of the fact that they are able to keep patients out of emergency rooms because of remote patient monitoring, and they're able to reduce that 30-day readmission. And it's been a really good venture for Mercy to utilize this virtual healthcare. So it's going to be around. So lessons learned, equipment doesn't need to be expensive. I've said that probably 5 times already. Learn from others. High satisfaction scores have been given for services. Patients really do appreciate telemedicine. Hey, it's still medicine. Technology is just the tool. Someday we may not even call it telemedicine, we'll just call it medicine. Plan and practice for telehealth, that's really important. I really stress that with my organizations, is before you go live, you practice on each other so that, you know, when you go live, you're more comfortable with it. And remember, telemedicine is definitely a process and it's not a destination. I would like to invite you to attend the National Consortium of Telehealth Webinars series. They're the 3rd Thursday of each month. The one coming up, July 16th, is going to talk about digital marketing best practices. So we invite you to join that. You register by going to telehealthresourcecenter.org, and we hope to see you there. This is the telemedicine echo that I was talking about, that even though it's for Heartland, we have other people from other states join. So if you would like to join, I think we're going to be talking about school health, maybe the next one, I'm not sure. But that is going to be next week, the 14th. And then I just want to give a shout out to South Central Telehealth Resource Center. Their learntelehealth.org website is absolutely awesome. And I encourage you to take a look at that and to get with those folks. And then our website, if you want more information about Heartland, please go to heartlandtrc.org. And if you have additional questions, just give me a call. Email me, it doesn't really matter. You know, I'm here to help, as well as South Central is there to help too. So I'm happy to answer any questions that you may have.
Thank you. Thank you, Janine, for providing us that great presentation. So I have unmuted everybody. You're able to unmute your own mic if you have a question you'd like to ask to Janine. Or you can put it in the chat box as well. Joe has shared that he said this is a great presentation and thanks you for that. So, and I have to ditto that. It was wonderful. I do have a question. I know you've been working in rural care for a long time as well. What have you found to be the biggest challenge in offering telemedicine to rural populations?
Well, prior to COVID, it was reimbursement. I mean, that was just that was it. But now, I think is what I have heard from my friends who are in organizations that would like to expand their telehealth offerings. It's just time. It's been difficult at best to get things ramped up and going during this whole crisis. And so you know, it's just time management right now is what some of them are dealing with.
One other thing I wanted to ask too, on some of the resources that you shared, is there a template that folks can use in working to determine their return on investment, their ROI?
You know, that is a great question, and that is something that we are working on right now because we've had that question before. And so we decided that we're going to create some kind of toolkit. So it's not ready yet, but as soon as it is, I will let you know.
Okay, and I have another question here from LaShannon Spencer, CHCA CEO. She is asking, can you please provide information or an update on reimbursement for FQHCs in Missouri as it pertains to telemedicine. And to add to that, is there any potential changes after COVID that could negatively impact that as well?
Well, I do know that there's a group right now that they're lobbying. Okay, so we can't lobby, but we have people that do, and they're really working at trying to keep these changes for FQHCs and rural health clinics after COVID, and so that they can continue. The whole thing is that if they're investing in telemedicine, investing time and money into telemedicine programs, and then COVID COVID ends, I hope someday it does, that that we don't want that money or time to be wasted. Okay, and so why wouldn't they want to continue with that? It's healthcare access, and that's huge. As far as the FQHC in Missouri, if you go to heartlandtrc.org and hit the COVID button, on our website, we have all 3 states, Oklahoma, Kansas, and Missouri, listed, and you can go into the Missouri regulations and look at those updates on reimbursement for FQHCs in Missouri.
Thank you. Thanks for sharing. We do have another question here. It says, how is Ms. Tracy seeing most primary care clinics schedule telehealth appointments is the first question.
How are they scheduled?
Yeah, how are most primary care clinics, I guess, scheduling telehealth appointments?
Okay, so I don't think I said this. If you've seen one telemedicine program, you've seen one telemedicine program. Everybody's a little bit different because every organization is unique in how they do this. There are some that are pretty sophisticated in that the primary or the health provider may see an in-person appointment and then go to his office and see a telemedicine appointment and then just interchange like that, throughout the day. Others tend to, prior to COVID, would maybe take an afternoon, like Thursday afternoons are my telemedicine appointments, or maybe 2 hours in the afternoon on Tuesdays and Thursdays, that type of thing. It's whatever worked for that provider and however they could schedule that in. But seeing that there were the ability to get reimbursed for telemedicine during COVID, we just saw it escalate into a little bit of in-person and a little bit of telemedicine, kind of back and forth that way.
Okay, I think she had some additional questions associated with that. So one of the questions was, are the appointments mixed in throughout the day? I think you kind of answered that it's kind of up to folks to decide what works best for them.
Right.
But she also said, we're having a hard time bouncing back and forth between telehealth and in-person.
Yes, that is something that people have said as well. And it's just a matter of, it's just a matter of getting used to it. They are different. I mean, sitting in front of the monitor, you can sit there and see them, one patient after another. But I will say that there is something now they're calling Zoom fatigue, and that healthcare providers are experiencing this, and that it's important for people to get up and move around and not sit in front of the monitor, in front of the screen all day, every day. So for the health of the healthcare provider, it might be better if they do have a little variety instead of having like this day is my telehealth day, and it gets your eyes get tired and you're sitting too long and that type of thing. It's a real thing. And I think there's even a webinar about that with the AAP. They're talking about Zoom fatigue.
Great. Thank you. Thank you for sharing. Well, we've actually gone just a bit over, but you can tell people are very interested in this topic, and we appreciate you joining us and being part of this today. Miss Gracie. But I want to thank everybody for joining us today and for all the insightful questions that we received. You will receive another email after this with a short evaluation, and we do really appreciate your feedback. So we look forward to hearing from everybody on that. And again, if you have not registered for the remaining 7 webinars that will be held every Thursday from noon till 1 for the next 7 weeks after this, please do so and tell your colleagues to join us as well. So with that, I will say have a great afternoon, everybody. We appreciate you joining us, and we look forward to having you back next Thursday. Thank you, Ms. Gracie, for joining us and for your wonderful expertise and insight.
Thank you.
Bye-bye.